Hi everyone, my name is Lauren Minark. I'm clearly at the airport and not at API trying to do my presentation because of a bunch of barriers, but isn't that just like being an OT at API? We are always running into barriers. So I'm going to start sharing my screen and get started. Okay, and present. Great, hopefully it loads. Okay, so my presentation is on the OT role in discharge in the acute mental health setting. Okay. So we have several roles just as an OT in a mental health setting, and I thought it would be good to start there just so everyone understands kind of what we do because it can be really confusing. We communicate and advocate to the staff, the team, the patient themselves, and caregivers if necessary. We develop protocols and facilitate therapy groups. The RTs also do this, but sometimes our groups are more focused on specific goals, community reentry strategies, sleep hygiene, a variety of skills, body image issues, ADLs, IDLs, money management, medication management, etc. We also address, I'm on number 3 now, physical impairments in the mental health setting. This could be related to Parkinson's, Huntington's, TBI, etc., and working on movement in relation to ADLs and IADLs, as well as fittings for wheelchairs and walkers. On number 4 now, we also do cognitive assessments and functional performance assessments. This looks like clinical observations, and sometimes you'll see us in the kitchen and you're like, why are they baking cookies? It's because we're trying to maybe assess cognition and see how a patient can do with sequencing and following steps. And it's actually a really great way to get insight into someone's cognition by watching them do a task. So this is something we like to do. Number 5, we help patients cope with the everyday challenges of living with a mental illness. And this can look like coping skills. It's hard to distinguish because it can sound like that's psychology, but it's more living with the mental illness, not necessarily talking through it and diagnosing, because that's not within our scope. It's more, can you access that mental toolbox of skills when you need it? And how are we going to live with this to be independent and successful? And lastly, we assist the patients in organizing their daily activities, ADLs, IADLs, and maximizing independence and performance in whatever deficit areas we have found. This can include home management, self-care, hygiene, grooming, leisures, hobbies, which is leisure and hobbies is RT, but we can also do that as well. Community integration, social participation, job exploration, medication management, kind of everything. Okay, so according to an article, and the citation is there at the bottom if you want to do some more research, there are several barriers that kind of relate to OT in this setting that can be barriers to a successful discharge. First off is just a general lack of health resources. This can include education to the patient, lack of funding, which is out of our control, housing could be inappropriate, or funding again, and it could be a lack of community support. This could be caregivers or just community support groups, anything like that. Another barrier would be patient deficits in medication compliance and management, which could lead back to discharge if they're not able to either do that themselves or have a caregiver help them out with that. Number 3, that little third sticky note there, it could be just the lack of overall communication and education with the patient and or their caregiver. That leads to just general confusion and in the discharge process itself. That can lead them to be overwhelmed and come back. Another point is a patient inability to successfully perform those ADLs and IADLs. If we let them out prematurely and they don't have enough support or independence in these areas, they could come back. A lack of communication and collaboration between us, the treatment team. That is one of the barriers that kind of stood out to me the most because it's not directly related to the patient, but indirectly affects them a lot. If we're not all on the same page or we're not reading each other's notes, which is almost impossible to do, but or attending the meetings, it can be a barrier to that patient if we're not all on the same page and able to attend their treatment team meetings to make sure that we're all have a common goal. In alignment with this, if the patient goal conflicts with our treatment team's agenda, or they have unrealistic expectations, or we have unrealistic expectations, this can be a barrier. In general, as I talked about before, symptom distress and social and emotional distress upon discharge can lead to readmission if they don't feel properly supported. Lastly, if they discharge, I kind of touched on this, to an inappropriate setting or too short of a stay, if we weren't able to do those cognitive assessments and kind of see those deficits quick enough, they could return. These are just some of the barriers, but these are the ones that kind of related to our setting and OT the most in my eyes, and API. Okay, so here's just some articles for future investigation if you wanted to look into discharge some more, and kind of went into my presentation. Basically, the first article was just studied that discharge planning is a known key factor in patient quality of inpatient care, and very important for decreasing readmission rates. And this, they found a main key in this was the perception and understanding among the hospital itself and us as staff of what this process even is, so that we can communicate it and we're all on the same page, so that we can give the best care possible. The second article I looked into kind of toots OT's horn a little bit, but it's not really meant to do that. But I included it because it did show through a study at a hospital that spending extra on OT services in the hospital setting was associated with lower readmission rates. And why this is because OT places a unique and immediate focus on the client. We are client centered and more holistic than a medical model. And our goals revolve around the patient's function and social needs, and these are very linked to readmission rates if left unaddressed. This is a handout I've been using as part of Discharge for several clients on my case, and I've been giving this to their caregivers as a visual and simple handout for me to provide them to explain and look back and refer to as they're working with this patient now, to bridge that transition from API and continue the services um, to their next location and to increase that success into the community. So as you can see, there's several different categories, but they're pretty broad. And the first is just safety concerns. And these are mostly anything that I observed in clinical observations or related to cognition. Examples would be impulsive behavior in the kitchen, staying away from sharps, lack of safety awareness, those kinds of things. Strategies are the things that I used personally that worked really well with the patient. This can also be the handouts I provide them as well and how to use them. The status summary is really important because often, like, I like to put where they are at this moment and explain that they're at their baseline and that there may still be some challenges, and what challenges to expect, and that they can reach out, and that I normally provide a number to reach our OT department here, and explaining just kind of the fluctuating status as well and what to expect when working with this patient. The OT goals to continue is really, really important, obviously, for OTs, because these goals revolve around the patient and continuing progress they started here into the community to motivate them and to keep them from readmitting. A lot of my goals revolve around self-care goals, making routines, turning in resumes, applying for jobs, cleaning the house, helping out their ELF staff, things like this. So this has been a really awesome resource for me to hand to that person to increase that caregiver education and bridge that gap. Here are two examples of real ones I did provide to staff. And the first one was an older patient, and you can pause this video and take a look at it. Basically, I just addressed any safety concerns that weren't already addressed in their documentation. That really stood out to me as could be potential issues at an ALF facility. And then, as well as that status summary that I talked about, strategies I used, this particular patient scored in a dementia category on a cognitive standardized assessment, and I put strategies on how to work and communicate best with an adult who has dementia in this section. And lastly, just goals to continue for her when she's there. The second one looks a lot the same, but it's very different because it's a different patient. Each report cannot be copied and pasted. They're very individualized. This one had